Some patients, they demand antibiotics from front. They will tell you that, I have to travel within few days, so it's better you start antibiotics rather than waiting. So we are in a dilemma whether to listen to them, whether not to listen to them, whether we should follow what we feel is right, or whether we should go ahead with prescribing antibiotics. So that's where what has led to this antimicrobial resistance globally. Let me tell you, the most common and the most important reason is lack of proper approach. Second, VRE, vancomycin resistant enterococci. Third, ESBL-E, that is extended spectrum beta lactamase enterobacteriales. Fourth is DTR-PSA or CRPA, that is difficult to treat Pseudomonas aeruginosa or carbapenem resistant Pseudomonas aeruginosa. Then fifth, we have CRE, that is carbapenem resistant enterobacterial. And finally, we have the CRAB, that is carbapenem resistant Acinetobacter baumannii. Treatment of multi-drug-resistant infections. So we all know that we have, daily come across patients who have come with fever, cough, cold, as simple as fever, cough and cold. And many of us are in always a dilemma whether to give antibiotics or not. Some patients, they demand antibiotics from front. They will tell you that, I have to travel within few days, so it's better you start antibiotics rather than waiting. So we are in a dilemma whether to listen to them, whether not to listen to them, whether we should follow what we feel is right, or whether we should go ahead with prescribing antibiotics. So that's where the beginning of antibiotic or antimicrobial resistance comes in. We all know that this is a common problem that we have come across. And many a times we start with antibiotics like cefuroxime, cefpodoxime, azithromycin, which are commonly used on OPD-based settings. But little do we know that in future, what kind of harm it may do to the same person who might get admitted later with a major pneumonia who is not responding to even azithromycin. So, or even a typhoid who is not responding to azithromycin. So that is the common problem that comes across. And that is the reason that has led to something called as antimicrobial resistant infections, which have become a global crisis. Internationally, approximately 1.3 million deaths were estimated to be directly attributed to AMR pathogens in 2019. So what has led to this antimicrobial resistance globally? Let me tell you, the most common and the most important reason is lack of proper approach. Whenever we see a patient, we directly ask few symptoms, ask for any past history, or we may ask if the patient is diabetic, check their sugars, if it is high, or directly prescribe antibiotic. Some patients may come with fever, cough and cold, and we don't think left and right, and directly we just prescribe with a penicillin antibiotic. That is what is contributing to antimicrobial resistance globally and also over a long term. So it's important that we have a right approach. But in this presentation for today, we are going to understand the principles of how to deal with an antibiotic resistant infection. To understand what treatment we need to give, we need to understand what we are targeting, which kind of infections we are targeting, why do we need a targeted antibiotic, and why do we need to approach this differently. So the most important or the basic idea that we need to know before beginning with the treatment is the mechanism of antibiotic resistance. Now, there are different mechanisms of antibiotic resistance depending upon the antibiotic, but the four common mechanisms are: number one, degradation of the drug by the cellular enzyme leading to drug inactivation, which happens when the drug enters the bacterial cell wall itself. The second one is prevention of drug uptake by altering the cell membrane permeability. When the cell wall protein gets altered, again it may cause or lead to antibiotic resistance. Third, modified binding site or alteration of the drug target. And finally, a drug efflux pump, which is inbuilt or there within the bacterial cell, which causes pumping out of that particular antibiotic. So these are the 4 common resistance mechanisms, but however, there are many other resistance mechanisms which has led to different organisms becoming resistant to antibiotic. So these are the common MDR organisms that we are going to deal with today. The first one is MRSA that we know, which is methicillin-resistant Staphylococcus aureus. Second, VRE, vancomycin-resistant enterococci. Third, ESBL-E, that is extended spectrum beta-lactamase enterobacteriales. Fourth is DTR-PSA or CRPA, that is difficult to treat Pseudomonas aeruginosa or carbapenem-resistant Pseudomonas aeruginosa. Then fifth, we have CRE, that is carbapenem-resistant enterobacterial. And finally, we have the CRAB, that is carbapenem-resistant Acinetobacter baumannii. Now, I'm sure many of us might have heard all these organisms in our microbiology lecture. But this is not just about understanding the organism, but understanding the resistant organism which we all are a part of contributing it to. So that's the reason we need to learn a little bit more about these MDR organisms that can help us decide which treatment is the best. Moving ahead, we have the first one, that is MRSA. Why is MRSA so special and why do we need to know? How did MRSA develop? It is because of something called as PBP2A, that is the penicillin binding protein 2A, which has contributed to the reduced affinity to beta-lactams. And it has become so severe that MRSA has not only become hospital acquired but also has become community acquired. So there are 2 kinds of MRSA, that is CA-MRSA and HA-MRSA. The community acquired MRSA is responsible for causing skin and soft tissue infections, necrotizing pneumonias, osteomyelitis, UTI, infective endocarditis, and sepsis. Now, why CA-MRSA is so bad or so important to deal with is because it carries a gene which is the SCC MEC type 4 gene, and this gene is responsible for producing the PVL toxin, that is Panton Valentin leukocidin toxin. This toxin makes MRSA so dreadful that it causes cavities, abscesses, skin soft tissue infections, and necrotizing pneumonias. The risk factors for CA-MRSA infections include IV drug users, serious underlying illness, previous antibiotic treatment, previous hospitalization, abscess, history of MRSA, and close contacts with skin infection patients. So that makes MRSA so important to deal with. And that's why we all know that MRSA, the major antibiotic that we use to treat it is vancomycin. But of course, there are other antibiotics too, like ceftaroline, ceftobipirol, vancomycin, teicoplanin, daptomycin, linezolide, tetracycline, and cotrimoxazole. Now, important thing to note here is daptomycin should not be used for MRSA pneumonia particularly, especially because the penetration is poor. So it is not just about which antibiotic for which organism, but it's also important where and what we are targeting at. Even the latest news that we know about Operation Sindoor and also the way in which the armed forces targeted the terror camps. So just like that, we doctors are also programmed to not just use a particular antibiotic to kill all the microorganisms, but it's important that we target only the bad ones and also target to kill only those ones. And that's the importance of treatment of MDR infections. If we go ahead with the next one, that is enterococci. It's basically a group D streptococci having naturally occurring resistant genes. There are 2 species, that is Enterococcus faecalis and faecium. They are naturally or intrinsically resistant to penicillins, tetracyclines, macrolides, clindamycin, and quinolones. So beta-lactam resistant, and hence the treatment we can opt for is Astriona, cephalosporins, and ticarcillin. Alternative treatment options we can go for are aminoglycosides and cell wall active agents like penicillin and vancomycin. There is high level resistance to gentamicin. So these are intrinsic properties of enterococci. But that's not what we have to learn today. What we need to learn is how to treat a vancomycin resistant enterococci. And for that, the treatment options we have are linezolide, high dose ampicillin, ampicillin sulbactam, doxycycline, chloramphenicol, tigecycline, daptomycin, and quinupristin dalfopristin combination. Now we'll go with an example. I would like you to put your answers in the comment box too in the next slide. So we have a 64-year-old female who has UTI with left-sided pyelonephritis. The urine and blood culture shows E. coli. This is the sensitivity profile. So can you suggest what is the treatment option or treatment choice you would suggest for this patient? So have a look at the sensitivity profile. You can see amoxiclav is resistant, cefoperazone sulbactam is resistant, ceftriaxone is resistant, and Restol sensitive. So please put your answers in the comment box, please. "64-year-old female with UTI with left-sided pyelonephritis having E. coli, and that is resistant to cefoperazone sulbactam, amoxicillin clavulanic acid, ceftriaxone, and we have different other antibiotics to which it is sensitive." So one answer we have is meropenem. Anybody else for any other answer? Cefuroxime. Anybody else for any other answer? Carbapenem. Piptars. Anything else? Meropenem, fosfomycin, ropenem. So we have a mixed answer. So we have some who are giving cephalosporin, some are giving carbapenem, some are giving amikacin, some are given piptars. So in this case, what was started is treatment started with IV piptars. Okay, so piptars was started with this. Now what happened? Let's see. The patient improved initially, then the fever subsided. Following which, 4 days later, patient started developing recurrent fever spikes. Again, they did a culture, and this time the culture was E. coli. So you can see here, it's all resistant, and I think the only difference is cefepime. Cefepime also has become resistant. Now can you tell me what is the next treatment of choice that you would suggest? Amikacin, fosfomycin, piptars, meropenem, okay. So everybody has suggested meropenem. Okay, now what we'll do is, it's important to understand what we are dealing with here. Here if you see, this is an E. coli, which is an enterobacteriales. Okay, that's right. Now you can see here, the patient is resistant to cefuroxime, cefoperazone sulbactam. Patient is resistant to ceftriaxone mainly. So that means that it is beta-lactamase resistant. What does that mean? That we are dealing with an ESBL organism. That is extended spectrum beta-lactamase enterobacterial. That is an ESBL, E. coli organism is what we are dealing with. And let's understand the properties of an ESBL organism. What is ESBL? It's an enzyme that inactivates most penicillins, cephalosporins, and aztreonams. Generally, they remain susceptible to carbapenems. They do not inactivate non-beta-lactam agents like ciproflox, cotrimox, and gentamicin. However, organisms carrying the ESBL genes often harbor additional genes or mutation in genes, expanding their resistance to a broad range of antibiotics. So it's not just E. coli that can be ESBL, it can be Klebsiella pneumonia, it can be Klebsiella oxytoca, and it can be Proteus mirabilis also. So one thing that we need to know is that for a case of uncomplicated cystitis or uncomplicated UTI, nitrofurantoin and fosfomycin can be used. But since this patient had UTI and pyelonephritis, nitrofurantoin and fosfomycin are not commonly used. So that is something that you need to know very importantly. Yes, you're right that we can use amikacin, that is treatment with a single IV dose of amikacin, or even an other aminoglycoside can be used an alternative treatment option, but that is only for an uncomplicated ESBL cystitis, but not for just a complicated one. Now, if you look at this slide, this is an important thing, which is an other enzyme which is associated with ESBL, that is AMC beta-lactamase enzyme. Now, these are enzymes that are produced at basal levels by a number of enterobacteriales and glucose non-fermenting gram-negative organisms. So, increased AMC enzyme production can occur in the presence of specific antibiotics and result in sufficient AMC enzyme in the periplasmic space to increase MIC to certain antibiotics. That is ceftriaxone, cefotaxime, ceftazidime, aztreonam, and piptaz. An enterobacterial isolate that initially tests susceptible to ceftriaxone may exhibit non-susceptibility to this agent after treatment with ceftriaxone is initiated. So I know that this can be a little complicated. One thing you need to realize is whenever an ESBL organism is isolated in the culture, do not start penicillin or cephalosporin group. Because even if, like in the earlier picture, you saw that cefepime, it was sensitive initially. If you would have started cefepime initially, then also patient would have developed fever later. Why? Because an ESBL organism can produce an AMP-C beta-lactamase, which may cause it to become resistant later. That is the take-home message in this slide. That is, an ESBL, I'll just repeat again, an ESBL organism, if you start any cephalosporin, even though the culture shows sensitive, it will become resistant in future because it may produce AMP-C beta-lactamase that may cause it to be resistant. So why we are dealing with this treatment of MDR infection is because it is not just selecting an antibiotic from culture and giving it. It's important to understand which organism we are dealing with, what is the resistance mechanism, and why we need to give certain antibiotics only and not just blindly follow the culture report. So this is the important study that was conducted, which is called as the Merino trial, where an effect of piperacillin tazobactam with meropenem was considered in patients with E. coli or Klebsiella pneumoniae infections in those patients who had ceftriaxone resistance. So a patient with UTI developed ceftriaxone resistance, he had ESBL E. coli, and one group of patients was started with piptas, one group of patients was started with meropenem. What did the study show? The study showed that patients treated with piptas compared with meropenem, the mortality was 12.3% versus 3.7% respectively. So these findings show that they do not support piptas compared with meropenem for these infections. Merino trial was a very landmark trial that discredited the use of piptas in ESBL infections. So this is something that you need to remember, and this is not something which is commonly discussed, so hence I put it in this slide so that you understand why piptas should not be used in an ESBL infection. Now moving ahead to what we call as carbapenem resistant enterobacterial. This is something that we commonly see in our OPD practice, where you have a diabetic patient with recurrent UTI, sometimes develops pyelonephritis, and you see that there is ESBL, E. coli or Klebsiella, and everything is resistant, and the only thing you see sensitive is fosfomycin or cotrimoxazole. Even meropenem, ertapenem, everything is resistant. So what to do in such a case? CRE are defined as members of enterobacterial order resistant to at least one carbapenem antibiotic, ertapenem, meropenem, imipenem or doripenem, or producing a carbapenemase enzyme. Resistance to at least one carbapenem other than imipenem is required for bacteria intrinsically less susceptible to imipenem. Nitrofurantoin, TMP, SMX, cotrimoxazole, or ciprofloxacin or levofloxacin are preferred treatment options for uncomplicated cystitis, although the likelihood of susceptibility to any of these agents is low. An aminoglycoside, a single dose, or an oral fosfomycin, or colistin, or ceftazidime avibactam, meropenem vaborbactam, imipenem cilistatin and relebactam combination, or cefiderocol. These are alternative treatment options for uncomplicated cystitis which are caused by CRE. So here what is important to understand that in an in a CRE isolate where you have resistance to meropenem, but it shows sensitive to ertapenem or doripenem, do not start ertapenem because we know it is already a CRE organism. So even if it is resistant to just one kind of carbapenem, it is important to avoid the entire group. And then we decide what is the next option we have to use. So when we encounter a CRE infection, what should we do? First thing is we should request something called as a Carba Expert. What is Carba Expert? Carba Expert is a PCR based test that helps to detect what is the resistance mechanism in these CRE infections. So if you ask your lab to do a Carba Expert, you will get the kind of resistances that are possible. One resistance mechanism is NDM, another one is KPC, third is OXA48, fourth is BIM, and fifth is IMP1. I agree these are all big terms that you may find it difficult to remember, but just remember these are all different resistance mechanisms, and knowing which resistance mechanism helps to decide which antibiotic will work perfectly. So first step is request Carba Expert. Second, we need to know the colistin MIC and also the meropenem MIC so that we can understand what is the level of inhibitory concentration that is present with colistin and meropenem MIC. Third is we decide on starting active antibiotics. When we do a carb expert, if you see an OXA48 resistance, the most suitable antibiotic that can be used is ceftazidime avibactam. But if you see an OXA48 and MDM resistance together, then we give ceftazidime avibactam plus aztreonam combination. The inferior options include polymyxins, and alternatives which can be used as adjuncts only include aminoglycoside, tigecycline, fosfomycin and cotrimoxazole. So whenever we encounter CRE infection, these are few things that you need to remember and decide as to which antibiotic we can use further. Now if we move ahead, we have something called as CRAB, that is Acinetobacter baumannii. It is probably the major terrorist group that we see in the microorganism level. Like we have Hafiz Syed, this is something that we fear the most, that is Acinetobacter baumannii. So in such a case, when we see Acinetobacter, we decide on the basis of culture. But if we have carbapenem resistant Acinetobacter baumannii, it is a difficult place to decide what to do next. The use of an antibiotic regimen, which includes a sulbactam containing agent, is suggested for the treatment of CRAB infection. So what we use as cefoperazone sulbactam, we blindly use it as one particular dose of BD. But we are not understanding that sulbactam is something which is a very good antibiotic which can be used for highly toxic microorganism. So the preferred regimen for CRAB is sulbactam durlobactam in combination with a carbapenem. But remember that in an Indian setting, sulbactam durlobactam is not very commonly available. So an alternative regimen that we can use is a high dose ampicillin sulbactam. That is, it is not just the 3 gram sulbactam that we use, but total daily dose of 9 grams of the sulbactam component in combination with at least one other agent like polymyxin B, minocycline more than tigecycline or cefiderocol if sulbactam durlobactam is not available. Now, whenever we see a CRAB, do we have to treat it always? No, that is something important, that CRAB organism can also be a contaminant. So every CRAB, if you start giving high dose sulbactam, the patient's good microorganisms will go and it will develop to pseudomembranous colitis also. So it is important to realize when to treat a CRAB infection. This is a study which was done about knowing whether CRAB is a colonizer or not a colonizer. If you have a positive CRAB culture, see from where you are isolating it, whether it is a non-sterile site or whether it is a sterile site. If it is a non-sterile site like airway, lungs or skin, we need to check for signs of infection. If no signs of infection, nothing to do, just observe. But if there are signs of active infection like fever, raised WBC, raised inflammatory markers, abnormal imaging, you are supposed to treat it. Now let's say we isolate a CRAB organism from a sterile site. Let's say blood, CSF, pleura or urine. In a sterile site, irrespective of whether the patient is having an indwelling device or a no indwelling device, we are supposed to treat it. But if the patient is having an indwelling device like any catheter or any tube, check for infections. Signs of infections, if it is present, you're supposed to remove the device and treat it. Don't just treat it and forget the device there. It's important to remove the device. That's the first thing to do. And if there are no signs of active infection, it is still important to replace the device, but you can observe and not just give treatment. So these are an important aspect of how to deal with a CRAB organism. It's not just about CRAB. Now let's just change it to how to approach. Like I said, what has led to antimicrobial resistance globally? It is the lack of proper approach. So what is the proper approach? The first step is to make a diagnosis. You have a patient, let's say with cough, let's say patient with fever and patient with breathlessness. So here your diagnosis is not pneumonia, but your diagnosis is a respiratory syndrome. That is the clinical syndrome you need to find out. If patient is having headache, neck stiffness, then it is not just an encephalitis or meningitis, it's a brain infection syndrome. Similarly, if you have a patient with burning micturition, it is a UTI syndrome. So you have to find the clinical syndrome first to understand which part of the body infection you are targeting. Second is step 2, that is empirical antibiotic therapy. Step 3, choose an appropriate antibiotic. How do you choose? Depending on 4 parameters. 1 is the spectrum of the antibiotic. 2nd, local resistance pattern. 3rd, penetration. And 4th, liver or renal failure. What is the pharmacokinetic and dynamic of that particular antibiotic? And finally, whether there is a need, and if there is, when can we transition to an oral therapy? This is the proper approach by which we can decide which antibiotic should we choose for an MDR infection. There are few things to remember. When determining an empirical treatment for a given patient, the clinician should also consider 3 points. The first is previous organisms identified from the patient and associated antimicrobial susceptibility testing data in the last 12 months. Second, antibiotic exposure within the past 3 months. And finally, the local AST patterns for the most likely pathogens. Now, this is something which we need to know. Every hospital will have its own antibiogram. If your hospital does not have one, you need to ask your microbiologist to create one. Antibiogram is basically a chart where you have the common organisms isolated from different sites of different patients coming to that hospital, and the common antibiotics that are susceptible to that particular infection. So they will produce a statistical analysis and you will be able to analyze which antibiotic can work in your hospital. That is a classic antibiogram. So this local AST pattern includes an antibiogram that is for the most likely pathogens. Apart from this, we know about transitioning to oral therapy. So transitioning to oral therapy should be considered assuming IV therapy was initially prescribed, particularly if the following criteria are met. Number 1, susceptibility to an appropriate oral agent is demonstrated. Number 2, patient is hemodynamically stable. 3rd, reasonable source control measures have occurred. And finally, concerns about insufficient intestinal absorption are not present. Now let's move to a next example. We have a patient with COPD with LRTI who was started with peptides plus azithromycin, which is the classical what we usually use, that is a penicillin group plus a macrolide. And what happened was patient developed type 2 respiratory failure, was taken on NIV support, finally landed up intubated. After being intubated, the patient developed high fever and patient was having a lot of secretions. It showed features of ventilator-associated pneumonia. Looking at this, he was started on IV meropenem plus teicoplanin. But the blood culture showed no isolate. But ET culture showed an Acinetobacter baumannii, which was resistant to cefoperazone sulbactam, meropenem imipenem, but it was found to be sensitive to tigecycline only. So how do we approach and what is the treatment of choice? Please put your answers in the comment box. We are dealing with a case of primary LRTI, which later developed into VAP. Meropenem and teicoplanin was not working. Peptides and azithromycin was not working. The isolate was a crab organism, that is the carbapenem resistant Acinetobacter baumannii, and it was resistant to cefoperazone sulbactam, meropenem imipenem, but sensitive to only tigecycline. That is as per the culture report. But what is the treatment of choice that you would suggest for this patient? Anybody for any answers? It's okay even if it might be wrong. It's nobody's perfect here. It's important to know that what we should choose, and this is how we learn. So would you start tigecycline? Would you not start tigecycline? Would you start any other antibiotic with it? Okay, we have one answer, that is meropenem plus tigecycline. Okay, but here you can see the patient is resistant to cefoperazone sulbactam and meropenem imipenem. So then what do we do? Start on tigecycline. Okay, so we know that patient is resistant to cefoperazone sulbactam, meropenem and imipenem. So, okay, resistant to amoxiclav also. All right, you are saying linezolide. Okay, ampicillin sulbactam. Okay, anything else? Poly B, aztreonam tigecycline. Okay, so everybody have given different answers. So let's just analyze what we are dealing with here. So we know that this is a respiratory syndrome, correct? We know that, okay, somebody has said prophylactic macrolides. So we know that azithromycin was given, not working. Okay, so we have a respiratory syndrome here. We have a VAP. We have an isolate, that is crab. When we have a crab, what did we discuss? That we would think of starting sulbactam. Now you can see here that it is sensitive to tigecycline only. One thing you need to know that lung penetration is a little poor in tigecycline. But of course, I do respect the opinion that ET culture shows tigecycline. So when we have a respiratory syndrome with an isolate of crab, what are the common resistance mechanisms that we see? So we know whenever we have a crab means that it has got everything, all kinds of resistance mechanisms. It can be OXA2B, it can be NDM, it can be flux pump, it can be PBP alteration. There are innumerable resistance mechanisms. So with crab, majority of them are resistant. In such a case, what would we do? To overcome all resistance mechanism, the most reliable here is polymyxin. So the treatment of choice will be polymyxin plus minus minocycline or polymyxin plus minus tigecycline, and just like somebody mentioned, polymyxin plus minus sulbactam. So definitely Dr. Ram Chauhan and most important Dr. Krishna Nair and Dr. Archana Babu who gave right answers. Yes, ampicillin sulbactam can be used, but the most preferable here would be polymyxin with a combination of tigecycline or minocycline or sulbactam. So that is one thing that you need to know, how to deal with a crab organism. So this is just a summary of the organisms, the common drug of choice and the mechanism of resistance. So MRSA resistance is PPB2A, drug of choice vancomycin. CRE, we know carbapenemase is resistant, so polymyxin, tigecycline, aminoglycosides. VRE, you will give daptomycin. MDR pseudomonas, you can give ceftazidime avibactam or ceftolozane tazobactam. MDR E. coli, you can give mesalenam. So these are all just as per different studies. So what I have told is based on the Indian studies. So these are all a cluster of international studies too. That's why we have antibiotics which are not commonly available in India also in this picture. Now let's go with few notable updates. 1. ESBL E. coli. These are all picked up from RCT trials. So I want you to remember these points. 1. Fosfomycin continues to not be suggested for pyelonephritis and complicated UTI. So please do not give fosfomycin for complicated UTIs. Number 2. Amoxiclav continues to not be a preferred agent for uncomplicated ESBL cystitis. Caution to be given to patients about potential which shows increased risk of recurrent infection if amoxiclav is administered for this indication. Third, piperacillin tazobactam continues to not be preferred for the treatment of pyelonephritis and complicated UTI. So this is something that you need to remember, that amoxiclav should not be used for an uncomplicated UTI also, even though it shows sensitive. Why is that? Because the chances of recurrence if once treated with amoxiclav is high. And with respect to piptas, you cannot or you should not use it for treatment of pyelonephritis and complicated UTI. Okay, but in some studies, what has shown is that, let's say you have a case of complicated UTI and urine culture shows sensitivity to piptas, and you have started piptas and patient has shown improvement, then what do we do? So there are several concerns, and many of the studies say that once you have started piptas and if suppose the patient has shown improvement, then you can continue with it and not change it. Okay, these are few clinical trials that have shown this. So that is something you need to remember, that only with respect to UTI, only sensitivity to piptas. If you start piptas, patient shows improvement, you can continue with it. But this is not applicable for a pneumonia, or it is not applicable for any other infection showing resistance to piperacillin tazobactam. Next is AMC beta-lactamase. As we know, it has intrinsic resistance to ampicillin, amoxiclav, ampicillin sulbactam, and first and second generation cephalosporin. Then we have a difficult bacteria again, that is Stenotrophomonas maltophilia. Questions have been adjusted to list agents in order of preference. Cefiderocol with a second agent can be used. Ceftazidime avibactam with aztreonam can be used. Minocycline with a second agent, or cotrimoxazole second agent, or levoflox as a second agent can also be used. Now we'll go to the next one, that is difficult to treat Pseudomonas aeruginosa. We know that piptas came into the market to treat Pseudomonas aeruginosa. But for infections caused by Pseudomonas aeruginosa, not susceptible to any carbapenem agent, but susceptible to traditional beta-lactam, admission or administration of a traditional agent as high-dose extended infusion therapy continues to be suggested. This is important to know. If it is resistant to meropenem or carbapenem, you can use a cephalosporin as an extended infusion therapy. Once daily tobramycin or amikacin were added as alternative treatment options for pyelonephritis or complicated UTI, which is caused by DTR aeruginosa. given the prolonged duration of activity of these agents in the renal cortex and the convenience of once daily dosing. So this is a notable update that has come for DTR Pseudomonas aeruginosa. Coming to CRAB, sulbactam durlobactam in combination with meropenem or imipenem cilastatin was added as the preferred agent for the treatment of CRAB infection. This is again, as I said, is an international study, so sulbactam durlobactam is not commonly available in India. Now the common points to remember. As I said, uncomplicated cystitis, typically a mild infection. If an antibiotic not active against the causative organism was administered empirically for uncomplicated cystitis, but clinical improvement nonetheless occurred, it is not necessary to repeat a urine culture, change the antibiotic regimen, or extend the planned treatment course. Please remember this point. If you have an uncomplicated cystitis and the antibiotic was resistant, but still you gave it, clinical improvement occurred, then you don't need to change it. Okay, you can continue it, do not modify it as per the culture, or do not repeat a culture, and do not give an extended therapy duration. However, for all other infections, if AST results indicate a potentially inactive agent started empirically, change to an active regimen for a full treatment course is suggested. So there is a difference between treating an uncomplicated UTI and all other infections where AST results do not match with the empirical therapy you have given. This is the recommended treatment options for infections due to CRAB. This is again another study which has shown. So every study need not be the same. Every treatment option they have suggested need not be the same. It's all dependent upon the local antibiogram pattern also. So in a CRAB, in pneumonia, colistin was given with a colistin based activity. The dose is mentioned here, do not bother about it. Plus minus imipenem cilastatin or meropenem with an adjunctive colistin inhalation. Bloodstream infections, again colistin plus minus imipenem cilastatin or meropenem was given. Alternative, you can use a sulbactam, as I said, higher dose, or colistin with tigecycline with sulbactam. So these are all just different treatment options. So if you want, you can take a screenshot of it if needed, or you can refer to it later. So this is for pneumonia and bloodstream infection. Now if we look at carbapenem-resistant Pseudomonas aeruginosa or DTRPA, in such a case the treatment option can be piptas, or you can give ceftazidime, cefepime, cefpirone, ciproflox, levoflox, amikacin. And clinical syndrome due to DTRPA, you can give a colistin monotherapy or combination therapy, ceftolozane, tazobactam, ceftazidime, avibactam, imipenem, cilastatin, relebactam. Remember one thing, there used to be a time when people used to say that if you're giving colistin, you have to give meropenem along with it. This is a very wrong concept. People say that if you give meropenem with colistin, then only the colistin will get absorbed. It's a wrong concept. Colistin can be used as a monotherapy, and if you find meropenem resistant, do not give it. You can just give plain colistin, and that is what studies have shown. So plain colistin is also a fine treatment option. Next, if you look at this treatment for CRE, that is carbapenem-resistant enterobacterials, you can give ceftazidime, avibactam, meropenem, vaborbactam, imipenem, cilastatin, polymyxin-based combination along with tigecycline. If you have a complicated UTI, you can give ceftazidime, avibactam, meropenem, vaborbactam, again imipenem, cilastatin, and even aminoglycosides. Complicated intra-abdominal infection, again with CRE, you can give ceftazidime, avibactam with metronidazole, tigecycline, polymyxin-based combination, colistin plus tigecycline. Then if you see, we have vancomycin resistant enterococci, where you have treatment option for pneumonia as linezolide, for bloodstream infection for linezolide or daptomycin, complicated intra-abdominal infection like linezolide, tigecycline, complicated UTI linezolide, daptomycin, uncomplicated UTI fosfomycin, nitrofurantoin, amox, ampicillin, etc. So these are all commonly used antibiotic therapy. Now if you look at this, in each of these charts that I've presented, majority of them do not show the duration of antibiotic therapy to be more than 7 days. What happens is, whenever we start treatment, if we see a patient who is improving and suddenly patient develops fever spike, what we do is we will continue it for 10 days, 14 days, randomly we would do that. Remember one thing, it's not just about giving the right antibiotic, but it's also important to give the right duration. If you give more than right duration, that also contributes to antimicrobial resistance. So duration is most important. So if you look at all the slides here, everywhere the duration, most of it is nearly up to 7 days or maximum 10 days. So this is something that you need to remember. Now, the most important and the last slide. Most common irrational fixed drug combinations. Meropenem sulbactam, meropenem tazobactam, meropenem EDTA and polymyxin EDTA. These are the commonly used combinations that have come to the market recently and that have been recommended by different pharmaceutical companies suggesting or citing different studies. But please know that there is no RCT to prove that this combination works against any infection. Now let me prove it with a little bit logic. If you look at sulbactam, what is sulbactam? It is basically a penicillinic acid sulfone, which is an antibacterial activity against beta-lactamase. Okay, now there are different kinds of beta-lactamase. One is beta-lactamase category like A, B, C and D. If you look at the carbapenems, okay, these carbapenems are responsible for, or you can say the beta-lactamases which are known to produce resistance to carbapenems that include KPC, AMC, NDM and OXA48. All these resistance mechanisms, they are not inhibited by sulbactam or even for that matter tazobactam. So what is the ideology behind combining two antibiotics? Is that you have an antibiotic and the other one is to overcome the resistance to the enzyme. But sulbactam or tazobactam does not overcome the resistance to enzymes which are affected by meropenem. I hope you're getting my point. So meropenem with sulbactam or meropenem with tazobactam do not hold any relevance in today's practice. Now coming to meropenem EDTA and polymyxin EDTA. What is EDTA? So whenever we have an EDTA is basically, have you heard of another resistance mechanism which is called as MBL, that is metallo-beta-lactamase. These metallo-beta-lactamase, they depend on zinc ions for their activity. And this EDTA chelates the zinc, thus neutralizing MBL. Are you able to get me? So basically the resistance mechanism that is metallo-beta-lactamase, to overcome that resistance, EDTA was used. But there is no proven RCT literature that shows that meropenem EDTA or polymyxin EDTA works. There is only a retrospective study. So I would always suggest that if any new antibiotic comes to the market, it has to be RCT proven. If it is RCT proven, you can directly go for using it. If not, it's better to wait and observe rather than causing more harm to the patient. So these are few aspects that I wish to cover regarding the treatment of MDR infection. I would like to ask something which I don't know, which is an interesting fact that many of us might not know. What I discussed about a resistance mechanism, that is MBL, that is metallo-beta-lactamase. Now, what happened is that this MBL has another name, which is called as New Delhi metallo-beta-lactamase. This is another resistance mechanism. How did this name come into the picture? Why is New Delhi named after, a resistance mechanism which it gives a very negative impression? So apparently there was a Swedish patient who developed some kind of infection, and when they tried giving antibiotics, the antibiotics did not work. And when they checked the resistance mechanism, which was a gene-based study, they found out that it was metallo-beta-lactamase. And the clinical history of that patient showed that patient had repeated visits to India. So that is how the New Delhi metallo-beta-lactamase was labeled. But what happened was the Indian government and the Indian medical organizations, they started questioning as to how can you name a resistance mechanism just based on New Delhi just because the patient visited multiple times to India. And after multiple quarrel and negotiation, Lancet in the year 2010 released an article which apologized for labeling this resistance mechanism as New Delhi MBL, and they changed it to another name, but unfortunately we still remember by this name, and that's the unfortunate aspect. So this is just an interesting fact which I wanted to discuss with you. So I hope I was able to cover the common MDR infections and the treatment of these MDR infections. As you know that this is a very vast topic and there are many things to cover. So I have tried to summarize it in each of these presentations. So if you can go through it, it will help you to decide on which treatment you can offer to which particular patient. Thank you.
We do have some questions from my doctors.
Yeah.
I'm going to be taking one of your questions. So Dr. Can you talk about what your profile is to avoid MRSA?
So the prophylaxis that you can do is first thing, if it is an admitted patient with some infection, then of course, as I said, vancomycin and all can be used. But you can use quinolones, you can use aminoglycosides, which can be used to take as a prophylaxis. But majority of it, nobody gives as a prophylaxis for an MRSA unless an MRSA is isolated within the hospital itself. Okay, then you have to you have to propagate the preventive measures like isolating the patient, using hand washing, barrier nursing, and things like that. That is the most important to prevent or avoid MRSA. Okay, so antibiotic with no resistance seen commonly. Okay, so that is something which is a very questionable aspect, and yeah, I do agree that now majority of the antibiotics are becoming resistant. But I think the latest antibiotics, like if you see polymyxin B or ceftazidime avibactam, the resistance rates are much low. But I hope that doesn't become resistant in future. But of course, and another thing is it depends upon which kind of disease you're dealing with. Okay, let's take an example. If you look at typhoid. So if you see that we all know that ceftriaxone is a good antibiotic to use for typhoid, and the continuous use of ceftriaxone, RCTs have shown that majority of the typhoid strains isolated in different parts of India are resistant to ceftriaxone, and that is the reason they recommend to start azithromycin with a bolus dose of 1 gram and then 500 mg once a day for 7 days. So if you see, it depends upon the disease that we are targeting and also to analyze depending upon RCTs. So it's important to think in that particular way. Okay, if an organism is resistant to ceftazidime avibactam, can we overcome the resistance by increasing the dose? Please clarify. Okay, so there are no RCTs which suggest that, if it is resistant to ceftazidime avibactam, by increasing the dose, it will solve the problem. It's not like that. It depends upon any other isolate or why that resistance is happening. Okay, you have to check for other cultures, you have to check what is the current status of the patient, and also how are you analyzing that patient has become resistant. Is it because of recurrent fever spike? If that is the case, you repeat the cultures and see. Please do not blindly increase the antibiotic duration just because the patient is becoming resistant to a particular antibiotic. It's not just with respect to ceftazidime avibactam, it is with respect to any antibiotic. Yes, that's true that the ceftazidime avibactam have shown a few cases of adverse drug, resistance. I do agree with that, but in such cases, it's important that we analyze that what are the other antibiotics that are possible and also which part of the body we are targeting. Just like I said, if you know that tigecycline shows very less penetration to a lung infection, then we should think about other options as well. So it depends upon which part of the body we are targeting to and also which combination antibiotic can we use to choose. Duration of treatment in chronic prostatitis. Okay, I do agree that prostatitis is one infection that if it is chronic, you may have to give for a prolonged period of time. So remember one thing, the kind of rule that I follow is that it's not easy to remember every duration. But if you have an acute infection, go for an antibiotic treatment of 5 to 7 days and maximum 7 to 10 days if it is admitted with multiple risk factors. If you have a patient with osteomyelitis, abscesses, or even chronic prostatitis, you need long duration antibiotic, be it 4 to 6 weeks, and that is the minimum. Okay, like 4 to 6 weeks you have to give. Once you give 4 to 6 weeks, you analyze by doing repeated cultures, checking the counts and patient's clinical status, and then decide whether to continue it further. So of course, I do agree that it is a very subjective thing, but it's important to analyze it in a critical way to avoid antibiotic resistance. If an organism is resistant to ceftazidime, can it be overcome by high-dose ceftazidime avibactam combination? Depends upon the organism that we are seeing. Okay, so just like I said that if it is a CRE organism, ceftazidime avibactam is the recommended one. Do not try to give only ceftazidime, it may not work or patient may develop fever spikes later. So that is important. Another thing is by giving high dose, it may not be very effective. By giving the recommended dose, it's effective. Only drugs like sulbactam works by giving high dose, number one. Second thing is an extended infusion therapy of antibiotic is proven to be better with respect to higher level antibiotics. So you can give an extended infusion dose, but it's rather than giving just one particular high dose therapy. Treatment for recurrent UTI in asymptomatic patient, lot of pus cells in midstream urine sample. The answer is no treatment. Please understand, asymptomatic bacteriuria does not require treatment. You keep treating it, it will just go for antibiotic resistance. The pus cells will not reduce. Patient is symptomatic, patient is having, indwelling catheter and things like that, then that's a different thing altogether. Now let's go for a symptomatic recurrent UTI. If that is the case, studies show that giving 3 months of nitrofurantoin or giving weekly doses of fosfomycin for about 4 to 6 weeks, these are all recommended studies which show that it has been shown good outcome. Okay, but of course it's important to weigh the benefit versus risk. Suppose you give a patient 3 months of nitrofurantoin, that patient will start developing pulmonary fibrosis. You understand? So what is important is you need to understand the benefit versus risk and then decide what to do next. Risk of secondary fungal infection in managing MDR treatment. Yes, I do agree with that in an MDR infection, the risk of fungal infections are high. But whenever you have an uncontrolled diabetes or immunocompromised patient post-transplant with a graft rejection or, all these kind of risk factors or patient on dialysis, these are all the risk of secondary fungal infection. But how do we predict it? So if suppose a patient is post-dialysis or recurrent dialysis and patient is having recurrent pneumonias, by getting a CT scan, by getting a biopsy or a KOH mount or a galactomannan test, these are few tests which can help us see whether it is a secondary MDR or whether it is a secondary fungal. So depending on that, you decide what to do next. Do not blanketly start multiple antibiotics and give one dose fluconazole. That is not the right way. It's important to prove it. Once you prove it, it's better to give the treatment for it. Duration of fosfomycin treatment in uncomplicated UTI. Basically, it is just a single dose. But as I said, that some studies show that recurrent UTI treatment, you can give weekly doses of fosfomycin for 4 weeks and see. But what I do is I give very individualized. Sometimes if it is a recurrent UTI, I will give it for 2 to 3 weeks, sometimes 4 weeks and then see. But yes, I have seen many cases where uncontrolled diabetic patients, once you control their sugars, their UTI level also comes down. But if sugars are very brittle, like there's rapid fluctuation and you have recurrent episodes of UTI every week, you can give fosfomycin twice weekly for 4 weeks. And I have seen that patient does not have UTI for nearly 6 to 8 months. So it's very individualized, so you can decide accordingly. Which books to read about antibiotics, its side effect and clearance? Okay, so there is an Oxford manual about antibiotics, you can read that. Then there are different journals, okay, like Journal of Microbiology, Journal of Pharmaceutical Therapeutics. So everything keeps on giving new and new updates regarding antibiotics. Another thing is you have an AMR treatment guidelines app. Okay, you can utilize that app to decide what antibiotic treatment you can use. So there are different ways, Nowadays you have chatbox AI. You can use your AI itself to see which antibiotic is suitable. If you just give the history and the clinical details, and if you give the resistance pattern, it can also suggest which antibiotics are good. So AI is not meant to replace doctors, but you can use it to give a better outcome for the patients. That is something you need to know. Most patients complain of adverse reaction to azithromycin in maximum number. Okay, so I don't think that with respect to oral tablets of azithromycin, there is much of a side effect. But if you're talking about oral, then it's better to check first thing whether you're giving any combination with it. We know that macrolides are known to prolong QT interval. Just check whether there are any other drugs going on for that patient, like amitriptyline or even as simple as statin. If it is going on, then probably it may be causing side effect. It's not just azithromycin, it may be because you're using it with some other drug which is causing the problem. Yes, I do agree that if you give IV azithromycin, many patients have a problem. So the hack behind it is that you give azithromycin not in 100 ml NS, you give it in 500 ml NS with an extended duration. Like 500 ml NS with 500 mg azithromycin IV you give for over 5 to 6 hours rather than giving it over 1 hour. So that can reduce the side effects for it too. Melioidosis treatment duration. So I have not come across much cases of melioidosis, so it will be difficult for me to comment on it. I think it's better you refer the guidelines related to it. So I think that is better. Carba test should be a good tool to decide the treatment regimen, OXA or NDM or both. It's both because when you use a Carba expert test, it shows all the resistance mechanism like OXA 48, it can show VIM, it can show NDM, it can show everything. So depending on that, as I showed in the presentation, you can decide which antibiotic you can use. So when you know that both are resistant, you can go for ceftazidime avibactam plus aztreonam combination or things like that. Okay, it varies depending upon what resistance pattern you're seeing. How to diagnose UTI in elderly. So whenever you have an elderly patient complaining of UTI, the best way is go for a midstream urine sample. You do the classical urine routine test. See the number of pus cells. Remember, in a female, up to 10 pus cells is fine, nothing to be done. If it is more than 10, then you need to find out if there's an infection. In a male, even if the pus cell is 3 to 5, it's important to diagnose it as UTI if the patient is symptomatic. Once you get to know that, then you go for a culture and start with the treatment of uncomplicated cystitis. Of course, depending upon the risk factors that patient already has. Wait for the culture. Once the culture comes in, you can decide whether to change it or whether to continue it. Use of cephadroxil in MSSA instead of cefalexin. So I have not used cephadroxil much. Okay, I think it's not very easily available also. Cefalexin is something which I have used for most Staphylococcus aureus infection, and if any penicillin group or any of that, say any of cephalosporin group will be useful in Staphylococcus aureus infection. Recurrent UTI in asymptomatic catheterized patient. So in such a case also, what I would suggest is to not go for treatment. It's important to see, I agree that many of us see a lot of pus inside the catheter in a chronically bedridden, catheterized patient. So in such a case, what you can do is you can put a long duration catheter like a silicone catheter, give it 4 weeks time, and if develops pus collection recurrent, you can try to change the catheter. That's all you need to do. Okay, but if the patient is having symptoms, patient is clinically symptomatic, then of course you need to go for treatment. Simply just boosting antibiotics and just dumping antibiotics into the patient is just going to do more harm. So that is something you need to remember. Does Candida tropicalis in urine culture require treatment? That is very subjective. Majority of the time when you see Candida, it's basically a contaminant. But if it is CKD patient, post-dialysis patient, immunosuppressed patient, cancer patients, things like that. And if you see that patient is having recurrent fever spikes and clinically patient is symptomatic and not responding to antibiotics, you can consider that Candida is significant in such a case. So it's not just, as I said, it's not just a culture sample that decides your treatment. It's the entire cluster of patient's clinical status, and also it depends upon the resistance pattern available and patient's risk factors. Optimum drug chart for routine and MDR spectrum. I'm not able to understand that question. It can just be a little more clear. Sir, even if IV antibiotic escalation therapy, few patients develop recurrent pyrexia, what would be the root cause? Now, let me tell you something. There are few patients, what happens is, whenever you see a patient is admitted in the ICU, you have given antibiotic, culture shows positive, you give antibiotic, then patient develops a fever, you add another antibiotic, then afterwards what happens, 3-4 days patient's fever is gone, then again patients develops fever, then you see another culture. But finally, sometimes the root cause is just drug fever. Stop everything, patient's fever will subside. That can be one cause, which is something which we don't come across very normally. And this has happened with one of my cases too. While I was reading about resistant infections about 2-3 years back, when I stopped all the medicines, the patient's fever automatically subsided. So sometimes it is just a drug fever or a habitual hyperthermia also. So it's important to correlate with your blood reports too. As simple as just a total count, neutrophilic count, lymphocyte count, ESR and CRP can help you decide whether patient's infection is increasing or not. You don't even require an expensive test like procalcitonin. So you can just use these basic inflammatory parameters to decide what to do next. Pus cells in URE in pregnancy significant value. Let me tell you, in pregnancy, any amount of pus cell is significant. Do not take it lightly. You have to treat it. Okay, because it is pregnancy. So even if it is 5 to 6 or 5 to 8 pus cells, you have to treat it. That is very, 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 very important. Cefpodoxime plus clavulanic acid, is it rational? So see, as I said, it is a rational combination, but as I said, that it is basically targeting the beta lactamase. So penicillin combining with a beta lactamase is rational, but there are antibiotics which have been disregarded right now, like for example cefixime plus ofloxacin, that has shown to be an irrational FTC. Okay, but you have to check for each and every combination whether there is an RCT proving that it is irrational or not. Okay, and use only rational combination. Suppose, let's say you have a simple case of URTI. In a case of URTI, you don't need clavulanic acid, because you know the common organisms are streptococci, common organisms are H. influenzae, staphylococci, and things like that. You just give penicillin, more than enough. Amox is enough, cefpodox is enough, cefuroxime is enough. You don't need to combine it with clavulanic acid. If you have a UTI, then of course you may think of clavulanic acid, nitrofurantoin, and things like that. So think and analyze and decide which antibiotic you need to use.
Okay, if we take a few more questions. Sir, am I audible?
Yeah, yes.
Yeah, is it okay if we take 2 to 3 more questions?
Sure, no problem.
Yeah, so highlighting the next question on the screen.
Should we report enterococci in ICU patient if the colony counting is not significant? Depends upon the susceptibility pattern. If you have a vancomycin resistant enterococci, yes, you need to report it. Okay, if you have a multi-drug resistant enterococci, yes, you need to report it. If not, it's okay. And every case need not be reported. Sometimes enterococci can also be a colonizer. So that is also important.
Dr. Naveen is asking for pregnancy UTI, which antibiotics is important?
So nitrofurantoin is a common antibiotic that can be used, and in pregnancy you can use amoxiclav also. Yes, I agree that recurrence rate is more, but in pregnancy it is important to also make sure that the risk to the fetus is less. So nitrofurantoin is a suitable option, and if nothing works out, you can give IV, and IV antibiotics can also help.
Sir, covered most of the questions. Thank you once again for taking so many questions very patiently.
Yeah, no issue.
There's a lot of appreciated comments and the emojis and reactions that are coming during your session, if you've noticed.
Yeah.
I'd like to thank you once again, sir. It was lovely having you back and really hope to see more of you. Thank you once again.
Thank you, Dr. Bashra. Thank you to the entire team for being so supportive, and thank you very much for having me here.